My name is Dr. Byron Izuka. I'm a fellowship-trained pediatric orthopedic surgeon. I did my training in Orlando, Florida under Dr. Charles Price, and I've been practiced here in Hawaii. I was trained like everyone else to treat stable elbow injuries with a long arm cast, which I did for years. But over time, certain complaints kept coming up with patients' parents, one of which was the difficulty in using their hand. They would sometimes rub in the thumb area of the cast and get some irritation there. And a real common complaint from parents was that they couldn't wash their kids' hands in the cast. And so it made me think, is that portion of the cast that extends over the hand really necessary to treat these fractures up at the elbow? So I sort of experimented and did some research, and I actually came up with a slightly modified version of a long arm cast, which I call hands-free cast. And it's like it sounds, it's a cast that just doesn't cover the hand, and that worked great for me. And I've treated kids with that for years and years. And again, kind of taking the KISS principle even further, I then began to ask myself, is a cast even necessary? Could I design a brace that has the same design as its hands-free cast and use that instead to treat these children? And that's when I approached Hely and Weber about collaborating. So thus far, the patients have absolutely loved the brace. Everything that it's meant or designed to do better than a cast, it has proven to do so. Probably the three things I tell folks that the brace is better at than the cast is that it does allow your child to be a little more comfortable because the hand and wrists are not tied up. They can do things, light things that we allow them to do a lot more easily. So things like writing, drawing, holding on to or playing with a toy, holding their fork to feed themselves, brushing their teeth. They can all do these things much easier if the hand's not tied up by the hand portion of the cast. And then of course the thing that I said drove me to really think about changing the design of the brace is the fact that the parents can now, if they're careful, actually wash their child's hands with soap and water. Again, with a cast, you can wipe their fingers down, but you can never really clean the hand well. And so for a lot of the mothers especially, they really appreciate that they can keep their hands actually clean and not sort of clean. Anyone that's motivated to take care of their arm in a way that's different and that can accept the fact that this brace will, in the right set of conditions and the right set of rules followed, do much better than a cast. Those are the patients I like to take care of because they're very excited about the brace. We haven't even put it on, and they're really excited about getting this brace. So the folks that you definitely shouldn't use the brace for are anyone where you think the fracture is even questionably unstable. So again, the primary indication is for stable elbow fractures in children. And if you're a pediatric orthopedist, I think you pretty much know what that is. Maybe a general practitioner might have a little bit harder time determining the stability of an elbow fracture. Certainly anyone, as you're having this discussion and going through this shared decision-making process, you get a feeling that either they don't understand or perhaps they're very uncomfortable with the idea of using a brace rather than a cast. It's probably better to go with the cast as the old standby. There are some people I think that sometimes maybe just don't understand despite your best explanations of what the brace can and can't do. And certainly I would not hesitate to instead use a cast for that type of patient. My approach to the use of the castaway brace is the same as for any other brace, whether it's for the wrist, the knee, or the ankle. It's a shared decision-making process, which means I explain to the parents exactly what the injury is. And the first thing I emphasize to them is for them to understand that this is a mild fracture, but this is definitely a broken bone. Every week, I don't know about other physicians, but every week someone comes to my office and is dismayed to find out that their fracture is in fact a broken bone. So I have to make sure they understand the diagnosis so that they treat the fracture, which is mild, but they treat it with respect and with the care that it should. So the first thing, make sure we're on the same page that this is a broken elbow. It does not need a cast. We're going to treat it maybe a little bit differently with this brace, but we're going to treat it well. And I tell them how to do it. And through this process, you can usually figure out their comfort level with this. And I'll sometimes ask them if they're comfortable with this approach. And most parents, of course, are. Many parents are, in fact, excited that your child does not need a cast and that can be treated alternatively with a brace. But we have to make sure that we understand that the brace has its limitations. And just like with a cast, there are things that can go wrong with the use of a brace. And I'll tell you that, anecdotally in my practice, I probably have more problems with kids getting in trouble with their casts than with their brace. Because with a cast, there are a lot of things that you have to do, keeping it dry, making sure things don't get inside. It's hard to tell when someone has a sore or a rash or an infection, something brewing inside a cast. And these are things that I've not had to deal with the use of a brace. Certainly someone taking the brace off is a concern, but again, as long as it's a shared decision-making process, everyone understands its limitations, what it's good for, what it's not good for, what the rules are, the do's and don'ts, everything seems to go fine. The great thing about this brace is that I think there really are so many angles that you can take for why it's better than a cast. So they're the obvious things that I talk about with the patients every time. The first is that it's removable, okay, and it has to be removed in a certain way. There are rules that you have to follow when it's off while your child's taking a bath, but it's removable, so problems with stink, itchy, and uncomfortable with the cast, they're avoided with the use of the brace. It is a time saver because it's a lot quicker for me to put on the cast at the visit and also to have the cast removed when they come back for their follow-up x-rays than it is to put on a cast and remove a cast. So the brace is a time saver actually in the clinic visit as well. Patient satisfaction, in today's healthcare environment, it's not just medical outcomes that count. How patients feel about the care they received is mattering more and more. And I think by using this brace, you actually get a leg up, if you want, on your competition, so to speak, who is still using the old-fashioned cast. I can just imagine the conversations that some of my patients may have with other patients when they bump into one another and someone's got this nice fancy looking brace and someone else has a cast, and we've got the same injury. I thought, how did you get that brace? And I got this cast. And this is the type of thing that over time, maybe not just one or two patients, but certainly hundreds of patients like I've treated now with my hands-free cast, and now getting into probably the hundreds with this elbow brace, is that patients are more satisfied with this. And so given two things of equal medical outcome, which ones do the patients appreciate and value more? Well, I think we're going to see that something like this is going to have a very meaningful impact on what patients perceive as value. So for the folks out there that are thinking about whether you want to try this type of thing or not, the advice I always give when doing something new is you hit singles and doubles before you go for the home runs. So again, if you're going to use this on someone, I would probably use it on a little bit larger child. So we have three different sizes. This is the medium that I have here, but there's a larger one and a smaller one. I would probably stay away from the smaller one in the younger child for the reasons that the younger kids tend not to be able to listen just because they're younger. And parents are, I think, a little more squeamish about their 3-year-old, which I have absolutely treated with this brace, but I'm comfortable with it. So I would probably start maybe with the toddler, the 6 or 7-year-old that has the type 1, totally non-displaced, totally stable supracondylar fracture as your first one. And get a few of those under your belt first. Get comfortable using the brace, get some confidence in the fact that the brace works as advertised, and then go to maybe a smaller child or a different type of fracture, or even one that is still slightly displaced, but definitely not unstable. So my personal indications for the use of brace, like anything else that we do in medicine, has expanded quite a bit from what I started with. I started off with stuff that was super safe, non-controversial, that I knew would not in any way get me into trouble, and I've expanded a little bit out beyond there. But that's how you start first. You hit singles and doubles, and as you gain confidence, you start to swing for the fence. But start off easy, become comfortable with this. Don't go for something that's don't bite off more than you can chew.